Hello students, welcome back to Medibits with Dr. Shraddha, where pathology meets medicine in the most practical way. Today we are diving into a very high yield topic, megaloblastic anemia. This topic frequently appears in university exams and NEET PG because it combines basic biochemical mechanisms, pathology and medicine all in one. By the end of this session, you will understand why these cells are called megaloblastic, how to diagnose and treat patients with this condition. So stay tuned till the end. We will also test your understanding with 3 NEET style MCQs with clinical case scenarios. So let's outline our roadmap for today. First, we will look at why megaloblastic anemia develops, that is the underlying pathophysiology. Then we will explore the biochemical link between vitamins B12 and folate and how they influence DNA synthesis. Next, we will move into the pathological features, what you will see on a blood smear and bone marrow aspirate, and then integrate that with clinical medicine including signs, symptoms and lab investigations. Finally, we will talk about treatment principles and consolidate your learning with 3 NEET style MCQs that mirror actual exam scenarios. Okay, now what exactly is megaloblastic anemia? It is a type of macrocytic anemia, meaning the red blood cells are larger than normal. But size is not the only issue, it is the reason behind that matters. Here the defect lies in DNA synthesis. Because DNA synthesis is impaired, the nucleus matures slowly while the cytoplasm continues to mature at its usual pace. This mismatch or nuclear cytoplasmic asynchrony leads to large immature cells called megaloblasts in the bone marrow. And the two main culprits are vitamin B12 deficiency and folate deficiency. Both vitamins are crucial for DNA replication and cell division, especially in rapidly dividing cells like those in bone marrow. Now let's understand what is really happening inside cell where biochemistry meets pathology. For proper DNA synthesis, your body needs thymidine, which is one of the 4 DNA bases. This thymidine is made when DUMP, that is deoxyuridine monophosphate, converts to DTMP, that is deoxythymidine monophosphate, a reaction that requires both folate and vitamin B12 as cofactors. When either folate or B12 is deficient, this conversion slows down. That means DNA replication gets stuck midway, especially in rapidly dividing cells like bone marrow precursors. So what happens? The nucleus stays immature while the cytoplasm continues to grow normally. This mismatch between nuclear and cytoplasmic maturation gives rise to large megaloblastic cells we see on blood smears. But there is more. Vitamin B12 has another important job also. It helps convert methylmalonyl coenzyme A to succinyl coenzyme A in fatty acid metabolism. Without B12, methylmalonic acid builds up which damages myelin, the insulation of nerves. That is why patients with vitamin B12 deficiency get neurological symptoms like tingling and loss of vibration sense. So an easy way to remember is B12 equal to brain plus bone marrow. It affects both the nervous system and the hematopoietic system. Now let's see what actually causes these deficiencies. Vitamin B12 deficiency often results from malabsorption, not just the poor intake. Remember, B12 absorption is a complicated process. It requires intrinsic factor from the stomach and an intact terminal ileum. So, in pernicious anemia, autoantibodies destroy parietal cells and intrinsic factor, leading to B12 deficiency even with normal diet. Other causes include ileal resection, Crohn's disease, and infection with Diphyllobothrium latum, the fish tapeworm. Vegans are also at risk due to lack of animal products. On the other hand, folate deficiency is mostly dietary or drug induced. Folate is easily destroyed by cooking, and certain drugs like phenytoin, methotrexate, and sulfasalazine interfere with its metabolism. Pregnancy and hemolytic anemia increase folate demand and can precipitate deficiency. Now, what do patients actually experience? Most symptoms are due to anemia, so they will complain of fatigue, pallor, breathlessness, and generalized weakness. Then some specific features. Tongue may appear smooth, shiny, and red, called glossitis due to epithelial atrophy. Because of increased destruction of immature RBCs in bone marrow, there is mild jaundice from elevated indirect bilirubin. The key differentiator is the neurologic involvement, seen only in vitamin B12 deficiency. This includes numbness or tingling paresthesia, unsteady gait, ataxia, and loss of vibration or position sense due to posterior column demyelination. Remember students, folate deficiency never causes these neurological signs. Alright, now lab investigations confirm your diagnosis. You will see anemia with raised MCV indicating macrocytosis. The reticulocyte count is low, showing ineffective erythropoiesis. LDH and indirect bilirubin rise because many immature RBCs die within the marrow before maturing, a process called intramedullary hemolysis. To differentiate causes, both vitamin B12 and folate deficiency increase homocysteine levels, but only vitamin B12 deficiency increases methylmalonic acid. That is your biochemical differentiator, and it explains why vitamin B12 deficiency causes neurological damage, since methylmalonic acid accumulation affects myelin metabolism. Now we will understand the morphology, which shows the big cell picture. This slide shows classic pathological features. On peripheral smear, you will see macroovalocytes, which are large oval-shaped RBCs instead of round ones. You will also see hypersegmented neutrophils with more than 5 nuclear lobes. So this is a hallmark finding. There will be low reticulocyte count because bone marrow cells cannot mature and enter circulation effectively. In the bone marrow, you will find that it is hypercellular but with ineffective erythropoiesis. The precursors are megaloblastic, that is large cells with immature nuclei, and you may also see giant metamyelocytes among granulocytes. So in this bone marrow picture, you will see there are cells in red circles and cells in blue circles. So these blue ones are the megaloblastic cells. You can see the size of these megaloblastic cells in comparison to the red ones. Red ones are normal bone marrow cells. Okay students, so these blue ones are almost twice the size of the red ones, which are normal, and blue ones are the megaloblasts. Okay, now let's simplify the key lab findings in megaloblastic anemia using an easy mnemonic, macro DNA, where M stands for macroovalocytes. These are large oval red blood cells typically seen on blood smear. A stands for anisopoikilocytosis, which means variation in size and shape of RBCs. C stands for cytoplasmic maturation greater than nuclear maturation. This reflects nuclear cytoplasmic asynchrony, a classic feature of megaloblastic anemia. R for raised MCV, usually more than 100 femtoliter, indicating macrocytosis. O for oval macrocytes and hypersegmented neutrophils, a very important clue on peripheral smear. Moving to the second half of the mnemonic, that is DNA. D stands for decreased DNA synthesis, the underlying defect in megaloblastic anemia, commonly due to B12 or folate deficiency. N again for nuclear cytoplasmic asynchrony, emphasized here because it's a hallmark feature. A for all cell lines are affected, leading to pancytopenia, not just anemia. So whenever you see this pattern, that is macrovalocytes, raised MCV, hypersegmented neutrophils and pancytopenia, think of megaloblastic anemia. This macro DNA mnemonic is a quick and effective way to recall the lab findings for your exams or clinical practice. So students, there are non-megaloblastic causes also which need to be ruled out. Alright, let's break this down in a simple way. Whenever we see macrocytosis, that is high MCV on a CBC, the first thing we must figure out is it megaloblastic anemia or non-megaloblastic anemia? Because both these types show increase in MCV. So MCV alone won't help us to differentiate. We need to look deeper, especially at the peripheral smear and bone marrow. RBC morphology is the key in megaloblastic anemia. The cells are oval macrocytes and we see hypersegmented neutrophils. This is a classic finding. In non-megaloblastic anemia, cells are round and there are no hypersegmented neutrophils. So if you don't see hypersegmentation, think of non-megaloblastic causes. Bone marrow findings in megaloblastic anemia shows megaloblastic changes. Basically, a maturation defect in DNA synthesis. Non-megaloblastic anemia has no such defect. Marrow looks different. Now causes to remember are megaloblastic causes include vitamin B12 deficiency, vitamin folate deficiency, and there are also drugs which cause megaloblastic anemia like methotrexate and phenytoin. Non-megaloblastic anemia causes include liver disease, alcoholism, hypothyroidism, reticulocytosis, and myelodysplastic syndrome. So basically, not all macrocytosis equal to vitamin deficiency. Always think of other causes too, especially in elderly or chronic disease settings. So here the key message is megaloblastic equal to defective DNA synthesis, oval cells, hypersegmented neutrophils, whereas non-megaloblastic is equal to no DNA defect, round cells, and there are other systemic causes. So now first things first, both vitamin B12 and folic acid can be given either orally or parenterally, which means via injection. The choice depends on the patient's condition and urgency of treatment. Oral route is generally preferred method of supplementation if there is no malabsorption. We use this in asymptomatic cases. Keep in mind, oral treatment takes time to show effects. So it's not suitable for urgent cases where rapid correction is needed. Parenteral route is preferred when the patient has neurological symptoms or there is an increased demand like during pregnancy or infancy. Also a quick note here, vitamin B12 is available in sublingual, that is under the trunk formulations also, which can be an alternative to injections in some cases. Now what about blood transfusion? If the patient has symptomatic anemia, you might need to give a blood transfusion to relieve symptoms. This is because vitamin B12 and folic acid supplements won't correct anemia rapidly. They take time. So to summarize, oral route use when stable, no absorption issues. Parenteral route, go for it if symptoms are severe or there is an high demand. And transfusion needed only in symptomatic anemia when immediate relief is necessary. So now let's talk about the dosing of vitamin B12 and folic acid. Once we have diagnosed a deficiency, it is super important to know how to treat it properly. Step 1 would be to identify and treat the cause. We need to understand why the deficiency is happening in the first place. For B12 deficiency, standard treatment is 1000 mcg IM B12 once a week. This weekly dose continues until the deficiency is corrected. After that, the patient is shifted to a maintenance dose either every month or every other month. Key point is the duration of treatment depends on the cause. If the underlying cause is reversible, say a temporary dietary issue, then once B12 levels normalize, supplementation can be stopped. But in permanent cases like gastric bypass, pernicious anemia, or other forms of malabsorption, lifelong supplementation is needed. Now there is an important clinical tip. Never give folate alone when the cause of megaloblastic anemia is uncertain. Folate can improve anemia, but it won't fix the neurological damage caused by B12 deficiency. That is why we say folate feeds blood, but B12 saves brain. So always treat the brain before the blood. Now, treatment of folate deficiency is much simpler. Oral folic acid 1 mg daily until levels normalize. No fancy dosing or injections needed here unless the patient cannot absorb it orally. So to recap the treatment, for B12 deficiency, IM injection weekly, then monthly based on the cause. For folate deficiency, give 1 milligram oral daily. Always rule out B12 deficiency before giving folate alone. So now that we have talked about diagnosis and dosing, let's break down the overall treatment approach for vitamin B12 and folic acid deficiencies. Dietary advice: always start by improving the patient's diet. It's a cornerstone of long-term management. Vitamin B12 is found only in animal-based foods like meat, eggs, and milk. So vegetarians and especially vegans are at higher risk of B12 deficiency. Folate comes from green leafy vegetables and citrus fruits. Encourage patients to eat fresh fruits and veggies regularly. In short, B12 is equal to animals and folate is equal to plants. Monitor the response. After starting treatment, it's important to know what to expect. Reticulocyte count, that is immature red cells, starts rising in 5 to 7 days. This is a good early marker that treatment is working. Hemoglobin usually normalizes in 6 to 8 weeks. But remember, neurologic symptoms take longer to recover and in some cases may not fully reverse if treatment is delayed. So always treat B12 deficiency early to avoid permanent nerve damage. Now special notes must know: pernicious anemia is an autoimmune condition. Patient will need lifelong IM B12 injections. There is no cure, only ongoing management. During pregnancy and in cases of alcoholism, folate needs increase. So supplementation is recommended in these groups. And if there is malabsorption, like in Crohn's, celiac, or post-gastric surgery, oral therapy may not work. We must give parenteral treatment. To summarize, fix the diet, monitor lab response, and individualize the treatment. Think beyond labs, watch for neurologic signs, and always consider special cases like pregnancy, alcoholism, or GI disorders. So after starting therapy, follow-up is very important. We expect reticulocyte rise within a week. That is our first sign of response. Hemoglobin levels usually normalize in 6 to 8 weeks. Neurologic recovery is slower. Sometimes it takes months, and if the deficiency is long-standing, nerve damage may not fully reverse. To prevent recurrence, maintain a balanced diet or continue B12 or folate supplements if there is an absorption problem. Patients with pernicious anemia need lifelong B12 injections and regular follow-up every 6 to 12 months. Overall, prognosis is excellent when treated on time. But remember, neurological damage can become permanent if therapy is delayed. So to summarize, megaloblastic anemia is equal to large cells due to defective DNA synthesis. Always think of B12 or folate deficiency when you see macrocytosis with hypersegmented neutrophils. Differentiate based on neurologic symptoms and biological markers. Treat promptly. Remember, B12 first, folate later. So now we will start with our MCQ discussion. There are in total 3 MCQs. First one consists of a clinical case, vegan with tingling feet. Question consists of a 45-year-old vegan presents with fatigue and tingling in feet. Investigation show hemoglobin 8 gram per deciliter, MCV 112 femtoliter. Peripheral smear shows macrovalocytes, hypersegmented neutrophils. Serum MMA, that is methyl malonic acid, is elevated. What is the most likely diagnosis? Your options are folate deficiency, vitamin B12 deficiency, iron deficiency anemia, or anemia of chronic disease. So the correct answer is B, vitamin B12 deficiency. Students, this question tests your ability to connect clinical features with biochemical markers. Here the patient is strict vegan, meaning low dietary B12 intake, since vitamin B12 is found only in animal products, that is meat, eggs and dairy. Tingling sensation and numbness in the feet indicate neuropathy, which is a feature unique to B12 deficiency and not seen in folate deficiency. Anemia is macrocytic because MCV is greater than 100 with hypersegmented neutrophils, which is a hallmark of megaloblastic anemia. The biochemical clue lies in elevated methyl malonic acid. This metabolite accumulates only in B12 deficiency because B12 is a cofactor for methylmalonyl coenzyme A mutase. So here is MCQ 2, which tests your pathogenesis concept, that is DNA block. So question is, which step in DNA synthesis is directly affected in megaloblastic anemia? Options are A, conversion of ribonucleotides to deoxyribonucleotides, B, conversion of DUMP to DTMP, C, conversion of succinyl coenzyme A to methylmalonyl coenzyme A, and D, synthesis of heme. So correct answer is B, that is conversion of DUMP to DTMP. Here this question checks whether you know where in the DNA pathway B12 and folate act. DNA synthesis requires thymidine, that is DTMP, and its production depends on the conversion of DUMP to DTMP, which is catalyzed by thymidylate synthase. For this step, folate donates a methyl group and vitamin B12 helps regenerate active folate from methylated forms. So if either vitamin is deficient, the thymidine pool decreases. DNA replication stalls and rapidly dividing cells like bone marrow precursors cannot divide, which gives rise to megaloblastic morphology. Now MCQ 3, which tests your clinical integration, the folate trap. Question consists of a patient with pernicious anemia. It started on folate supplements only. Which complication may occur? Options are A, exacerbation of anemia, B, neurologic deterioration, C, hyperkalemia, or D, thrombocytosis. So correct answer is B, neurologic deterioration. This question highlights a key clinical warning often tested in NEET PG. In pernicious anemia, problem is vitamin B12 deficiency due to lack of intrinsic factor and not folate deficiency. If you give folic acid alone, it can temporarily correct the anemia since folate bypasses the DNA synthesis block, but it does nothing for the neurological dysfunction that depends on B12 for myelin synthesis. In fact, it can worsen the neuropathy because the hematologic response masks the deficiency while neuronal damage continues unchecked. Hence the golden rule, always replace vitamin B12 first, then folate if needed. Thank you all for watching. I hope this session clarified the facts and connections from biochemistry to pathology to clinical medicine. If you found this helpful, please subscribe to Medibits with Dr. Shraddha for more integrated sessions like this. Our next videos will also cover another high yield and clinically relevant topics. Until then, keep revising smart and happy studying.